Okay. Thanks, Alex. Thank you, everyone, for joining us today. My name is Angela Siwan, and I am a support group facilitator for the in-person Burnaby Support Group and a volunteer with the ALS Society of BC. Welcome to Patient Information Webinar Series number 9. Please note that today's session is being recorded and will be posted on the ALS BC website for future viewing. We will have time for questions and answers at the end of the presentation. Please submit your questions using the Q&A button at the bottom of your screen. The Patient Information Webinar Series is proudly presented by Tanabe Pharmacare Canada. Today, we are pleased to welcome Elizabeth. Elizabeth graduated as a registered nurse from the Vancouver General Hospital School of Nursing in 1979. Her professional credentials include a Bachelor of Science in Nursing, a Master of Science in Nursing, and 2 Canadian Nurse Association specialty certifications in gerontological nursing and hospice palliative care nursing. Elizabeth brings 47 years of frontline clinical education and management experience, having worked in hospital, community, and long-term care settings. She currently works as a clinical nurse specialist for palliative care and end-of-life services with Interior Health. She is also a master facilitator and coach with Pallium Canada, teaching nationally and working in Canada's North, including the Northwest Territories and Nunavut. In addition, she holds a clinical instructor appointment with the UBC Faculty of Medicine, Department of Family Practice. Elizabeth is deeply passionate about supporting individuals and families living with advancing serious illness, including cancer and non-cancer conditions, across community, long-term care, and hospital settings. When she's not working, Elizabeth enjoys gardening, hiking, and birdwatching with her husband, Ted. She joins us today from Penticton.
Thank you so much, Angela. And hello, everyone, and a very good afternoon to everyone that's joining us today. I'm not actually able to see all the little Hollywood squares of people that have joined, and I'm not able to see the chat once I'm displaying the presentation today. So I am going to ask Angela and Alex if they don't mind monitoring the chat. And if at any point in time people have a question or need to pause me or re-explain something, happy to do that. Also would just say that I am going to leave enough time at the end that we can have a conversation and answer any other questions you have. So deeply honored. Thank you again to Alex and to Angela for inviting me to join you today. I want to start this out in a good and genuine way, and I'm just going to say that I am privileged and honored to join you from Penticton, which is traditional Salix territory of unceded traditional and ancestral lands. And I just love where I live and work now. We were just talking before the presentation how I have always loved where I've lived, previously in Nelson and in the Kootenays, but I am in Big Sky Country now. So I just want to say it is an honor to be able to join you from these traditional Salix lands. So today we're going to talk about a palliative approach to care. And I really want to help people understand, what do we mean when we use the word palliative? Because I think there's a lot of misunderstandings and quite often a lot of fear sometimes around the word palliative. We're going to talk about how people's abilities and symptoms come from the actual illness itself, from ALS, and how those abilities change as ALS advances. Some of you may be very familiar with the Canadian best practice guidelines for ALS. I'm actually going to use them as a little bit of our white line on the road as we walk through and talk about using a palliative approach and what do the guidelines say and what would that look like in terms of using a palliative approach. I'm going to introduce you to a few tools. One of them is going to be ESAS. And then we'll just hold a conversation at the end. And so any good questions you have, feel free to either pause me or mark them down and we'll talk about it. Okay. So very commonly when we use the word palliative, I often will see surprise, maybe a bit of fear in people's eyes. People often associate the word palliative with end of life care, the dark blue circle that you see on the screen here. They think about palliative as dying. They think about it as the end of life. And while it is true that palliative care does support people in those last days and weeks of life, we support people much, much, much earlier. And we use the word palliative differently for people who are living with a serious and advancing life-limiting illness. And we don't actually hold a clock to that. So we don't hold a calendar or say, well, palliative care is only for the last weeks or days of life or last 6 months or 1 year of life. There are programs that do put time constraints around the word palliative. That's got more to do with money than it does with people's needs. And so what you'll find is that palliative care actually is in the province of British Columbia, often the last 6 to 12 months of life, as decided potentially by a physician. So a physician would say, my prognosis would be maybe 6 to 12 months. But a palliative approach to care looks at supporting people long before they might be eligible for a program that has the word palliative in it. We know that people who are living with a serious illness, a life-limiting illness, and an illness that is progressing or advancing will experience symptom, stress, distress, functional loss, quality of life issues, long before they're eligible for a program. Right? So we use a palliative approach to care in our general care all the time. And, this model makes sense. This is sometimes referred to as a primary generalist model of palliative care. It makes great sense in the province of BC because I'm pretty sure some of you are joining us from the big urban centers in Vancouver and in Richmond, but some of you may be joining us from some very small towns. And so what's been very important, I think, within BC is that we've been working hard to bring a model of a palliative approach to care, to walking alongside and supporting people in all of the care that they deliver. And so making sure that we're trying to address what concerns people have much, much earlier, not waiting until the very end of life. So I'm going to be speaking about this whole nesting diagram, this whole continuum. And, you can study it and you can see that there's different parts that come to a palliative approach to care, when I might be eligible for, or the person I love might be eligible for the benefit program, the palliative care benefit program, and then when we might actually be right at the end of life care, but they're not the same thing. And the important part is to have support all the way through that journey. And that's what I'm hoping to describe for you today. So who delivers a palliative approach and palliative care services? Well, I would say to you, all healthcare professionals really should have the basic competencies, the knowledge, the skill, the abilities to support people that are living with any advancing life-limiting illness. So that could be cancer, that could be a non-cancer diagnosis, that could be ALS, that could be heart disease or lung disease diagnoses. Anywhere across that illness journey, we should have the skills and the knowledge to be able to say, if people are experiencing symptom burden, any sort of symptom distress, if function is declining, or if quality of life is being impacted, then we need to pay attention to this. In the larger cities, they do have specialized palliative teams, and those teams will use the last 6 months, often 6 months to 1 year of life, But even before that, there are general staff in those big health authorities as well, and they would use a palliative approach prior to somebody being eligible for the specialized services. In a health authority like mine, we don't have specialized services. We simply don't. We need to build the capacity amongst all of our staff so that all of our staff can do this work. And I've been doing this for over 10 years now, really working hard trying to get all of our staff to understand how to bring a palliative approach into care early on. So in our smaller cities and rural cities, that work belongs to whoever it is that you are meeting in the healthcare system. So in home health, in hospitals, if a loved one lives in a long-term care facility, it would be the nursing staff, it would be the social worker. It's all people, all healthcare professionals to bring a palliative approach early on and throughout, right to the end of life, to that little blue circle. Now, let's focus on ALS itself. We know that it is one of those serious life-limiting illnesses, that it's marked by changes in a person's functions over time, right? The illness actually reduces people's ability to manage independently, and it's often thought of as having like an early, middle, and a late stage. And long before we get to that little blue circle that you saw on the nesting diagram, there's changes happening all the way along there, right? So a palliative approach can be used in all stages, all the way through to support the changes, the transitions, to help with symptom burden, and to improve quality of life. And so we know just from the nature of ALS that people are going to have problems with motor function, with mobility, with dexterity, with speech and swallowing, and with breathing. So one of the tools that is very, very helpful, and it's actually available for you publicly, and it's in the ALS Canada website. It's probably you're familiar with it, or if you're not, you can take a good look at it, because I think it's a very simple, well-described tool. It's called the ALS Functional Rating Scale, ALS FRS, and the R just stands for revised. They've changed it a little bit over time, and it looks like this. And there are 4 sort of domains or areas in which ALS, as it progresses, starts to impact people and how their everyday life functions. And now that's a bit small for me to read, so I got to put my glasses on here. So the domains or the areas of functional loss are bulbar, which is part of the brain, and it affects people's ability to speak clearly, right? Your ability to manage your saliva and swallow your saliva. All of us swallow all the time, many times in an hour. So that ability to coordinate the swallowing and the management of your own saliva, and swallowing food and fluids as well. So you can see there's a rating system in there. The fine motor is about handwriting, being able to cut food as an example. They just chose finer motor functions that are common and everyday as a way of being very practical in this scale. And then dressing and hygiene, so a person's ability to button their shirt, for example, or to brush their teeth, that sort of thing. Gross motor is really around the larger movements that we have in everyday life. So our ability to climb stairs, or to walk independently, or also to turn in bed. We take that so much for granted, and that is one of my clinical markers as a nurse. Is I'll often ask people about, are you able to still turn yourself in bed? Right? And then the respiratory part, dyspnea refers to the feeling of shortness of breath. Shortness of breath. I feel short of breath and panting. Orthopnea is the word we use for when people have more shortness of breath and they're lying flat. So when they're lying down to go to sleep. And respiratory insufficiency means my breathing, I cannot breathe independently well enough to support myself. I actually might need some assistance, like a BiPAP machine, to be able to give me some added flow. And I might only need that occasionally, I might need only a little bit at night, or I might be needing it day and night. So as my need for more assistance with breathing increases, the scoring changes on this. So I don't think you need to worry too much about exactly which scores. You can always look at this yourself. This is not just a tool for professionals. This is a tool for you as well. And what we're always interested in is, how are things changing? So, higher scores mean everything's going is fine. Everything's going pretty well. And then as things begin to change, we start looking at the rate of change. So not an actual drop from one number to another, but over what period of time. And very generally, they use the 1 month as the indicator. So, if people are losing about a half a point per month, and things are progressing very slowly. If it's about a half to 1 point a month, as you see here, that's fairly normal in ALS. That's considered a normal pathway. And when things pick up and things are changing more rapidly, then that's a faster progression. So why that is important is for you and for your health team. Because if we know and understand how your illness is changing over time, we're going to be able to anticipate and support you even better. We know the change is coming before you end up in a crisis. We're able to anticipate what's happening next, and now we're able to start to address it much earlier on, right? So that's the reason why it's good to be thinking about, where am I in my illness? What is changing for me? What is the impact right now in terms of how I'm managing independently, or where I need more assistance? Now, in Canada, as I mentioned, you have a really amazing best practice guidelines for good care. This is the national standard for ALS and for its treatment right across Canada. There's a public version of this book for family members, and then there's the one that was published for the healthcare professionals. And I went back and I reread it. This is the most recent version. It's from 2022. They're probably going to be updating it soon, but it's still very valid. And I was really delighted to see that the language of a palliative approach and palliative care was right in your national guidelines. That is terrific news. So, palliative care is not a place. It is not like a hospice. It is not a room, long-term care facility. It's not the color of the paint on the wall or the pretty butterfly on the door. Palliative care is an approach, and it's an approach to supporting people and families that are living with a serious life-limiting illness like ALS. Okay? So I would like to talk a little bit about the Canadian guidelines, talking through them so you're familiar with the national guidelines, and that we talk a little bit about the palliative care and a palliative approach, and that will give you a really good idea about what I'm talking about, and maybe take a little bit of the fear out of the word palliative. I hope it does, because to me, palliative care is just good care. It's just good care all the way along, companioning and supporting people. So, and that's very much what your guidelines said. They said that palliative care and caregiver support are important components for assisting people along their journey with ALS. They didn't say at the end of ALS. They said along the journey. And it's an approach that addresses the person as a whole, not just the disease. So that's very reassuring. So indeed, when I say start early, I mean early. I mean, it can start as early as at the time of diagnosis, because people get diagnosed at different stages and different phases of illness. And I do think your guidelines do say that. They are saying that although some people may not want prognosis and diagnosis, let's just tease those out. Diagnosis is confirming a condition or an illness that has been investigated, and that a neurologist, for example, has confirmed ALS. Prognosis is about how long do I have to live? And there will be some people that want to know that. They want to know right up front. And there'll be other people that are like, nope, I don't need that information right now. I just need to know a little bit about what I can expect. and what lies ahead for me, right? The important point is however people, how much information they want and when they want it, is that we're talking. That's the piece I want to say. Talking with your healthcare team is a good thing. And those discussions, and that's what the guidelines say, those discussions can be tailored to best meet your needs. So different people, different wants. Some people will want to know all about the diagnosis of ALS. Some people will want to make sense of the changes that they're experiencing in their body and in their abilities. Some people do want prognosis, and other people say, what can I expect maybe in the next 6 months? Don't tell me the whole picture. Just tell me and what can I expect in the next few months, and how can I prepare for what lies ahead? So however much information people want, we want to be respectful. And it's very common for a healthcare professional to even ask you, how much information about your condition would you want from me? So we're seeking your permission to have honest conversations. Okay? A palliative approach would address all of those concerns and issues. That's why we can use a palliative approach right at the time of diagnosis. So there's a big section in your guidelines around advanced care planning. We want to talk about that because it's not just for ALS that advanced care planning is important. In fact, advanced care planning is important for everybody, whether you're healthy, so every adult. I just want to add that, for every adult, whether you're young, whether you're old, whether you're healthy, whether you're ill. Advanced care planning is actually something we should all be adulting, is what my children would say. Oh, Mom, I'm adulting. Absolutely. We all should be thinking about advanced care planning. So advanced care planning, what it is, it's about saying, if I can't use my voice to make decisions, first of all, what matters most to me? What is my wishes, my values, and my preferences? But if I can't use my voice in the future, at some point, who do I have in my life that I would trust? And what do they know about what I would want? Okay? So the guidelines say advanced care planning is an important aspect of ALS management because it helps establish a person's preferences before the disease is advanced and communication is impaired. These conversations should be started early or whenever a person with ALS inquires. And that's exactly the approach that a palliative approach would say. And in fact, we have a very big push within British Columbia for people, and I'm sure your ALS Society has been doing this as well, helping people understand what advanced care planning is, thinking about, what matters most to me, thinking about who do I trust, talking with them, maybe talking with your doctor, with your nurse, and then making a plan for yourself, and then choosing to finalize this process by putting in place a Representation 9 agreement, that's for health, and an enduring power of attorney for finances, and then sharing that document, with the other person who you've chosen, sharing it with their doctor so they know. This is its own talk, ACP and advanced care planning, but it is so important. And there is a very lovely movie if you're looking for something you're thinking about this, but you're not sure. I urge you to look and Google Love is Not Enough, ACP. And it's from Australia. And it talks about the importance of how all of us, we just never know what the future is going to bring. So even if we're young, even if we're healthy, we all should be thinking about, if I can't speak for myself, who speaks for me? And of course, the law and the health system always honors the person's original voice for as long as they can, in any way that they can, right? So we would never override when somebody can still make their decisions. It's only if they haven't got the mental abilities or there is no way of understanding the communication. You see a few of the resources there. Your health authority will, if you look at their website, My Voice is from the BC Ministry of Health, and NIDIS is a very good source of information as well. So the other form of talking is something that has the brand name to it of serious illness conversations. So you may have heard of this. Some of you may have had this. Some of you may have never heard of this. And these are listening conversations. And surprise, the listening is actually the healthcare professionals. Instead of imparting information, we're actually trying to teach doctors and nurses. Social workers are pretty good at this, but all of the team to use a type of a conversation with some set questions in it to explore what you understand of where you are in your illness, to ask about, what matters most to you and what are your goals, your fears, your worries. What is quality of life? Only you can define what quality of life means to you. And it's out of those conversations that we would say, okay, we will therefore make sure that the care that we're giving aligns with what you wish, with what you prefer. We call that goal concordant care. It's a big fancy name, but it just means, you know what? We're not pushing care or options or treatment that you are saying that wouldn't match. That would not match what I would want for myself, right? And so we should be having these serious illness conversations early and often from the time of diagnosis all the way through illness, because people have lived experience. And what I thought I wanted 6 months ago, 2 years ago, maybe it's looking a little differently. I have a different experience of my illness, and, I have something different that matters to me now. So that's why we need to repeat these over time, slowly. So we can blend all of these palliative approach strategies with the guidelines. And one of the ways we can do that is we can be assessing people for symptom burden and distress. You saw in that nesting diagram that was a big piece, was addressing a palliative approach is about easing any symptom distress. We can support caregivers, and we can have conversations that are going to support people to understand what you need today, what you might need in the future. So I thought I'd just pause for a moment. And Angela or Alex, is there any questions in the chat that I need to address before I move on?
Yes, thank you, Elizabeth. We do have a question from Roger Yu. And his question is, we were told that one may be removed after a while on the program and still alive, in brackets, like after 1 year or two. Is there a time limit for one to stay on the palliative care program in BC?
That is such a great question, Roger. Thank you for asking. So that, what the Ministry of Health says is that the needs of the person should be reevaluated at 1 year. And if it is thought that they might have more than a year, another year to go. So if the eligibility for BC palliative care benefits is 6 months to 1 year. So if at the 1 year mark, actually your illness is progressing, but so slowly, and we're thinking, oh gosh, the physician thinks you have more than a year's left of life. It may be that they may decide that that program needs to end. That doesn't mean your palliative needs end. That just means that maybe they'll be meeting their needs through a different program, like a continuous nursing program or a home health program. In some ways, it's very good news. It's saying that they think you have more than a year to go. But absolutely, it should be needs-based and not clock or calendar-based in that assessment. Thank you for that. Excellent. Okay, I'm just looking at the time. I realize I hope I'm not going too slowly for people or too quickly, but I am going to pick up a wee bit of speed here and just get us through some of the symptom pieces. And so wanting people to understand that symptom burden can be complex. It's not just physical symptoms. So it's not just shortness of breath and pain. People have anxiety. They have, spiritual symptoms, cultural distress. There's many ways in which people suffer, and often they compound one to the other. And what we know is that people who either lack or have limited access, or they decline. They say, no, I don't need any visits. No, I don't need anything. But they're living with an advancing illness, that they are at risk for multi-symptom burden. So, one of the good things the healthcare system does is it assesses for multi-symptom burden. And we have to remember it's not just your illness that results in symptoms, treatments result in symptoms. Just think about things like starting a new medication and maybe getting diarrhea or an upset stomach or, so treatments themselves can cause symptom distress. So if you've never seen this is the most common way, and it's used around the world. We have Edmonton, Canada, to thank for this. This is called the ESAS tool. And on one side of it is the understanding my symptoms. You can see the faces go from happy all the way to not too happy up here on a 10. So a low number means I'm not having much problems with these symptoms. And a 10 means this is the worst I've ever had. And so there's 6 actual physical symptoms. So pain and tiredness, a loss of energy, nausea, poor appetite, shortness of breath. And then there's 3 psychosocial symptoms on here that we screen for: depression, anxiety, and best well-being. There's room for us to fill in 2 other symptoms like constipation, muscle twitching, maybe it's the salivation that's really distressing for people. So we can fill that in. And this tool gets informed by you, the patient. So research shows us over and over again that when family members estimate symptom distress, they overestimate. When healthcare professionals estimate symptom distress, they underestimate. It's the patient's voice as much as possible, or as long as possible, we want to capture. Now, they may not have the fine motor dexterity to fill this in. And so somebody could fill it in for them. And along the top, you probably can't see it, but there are, there is a completed by, and then it says the patient, the family caregiver, a healthcare professional, a caregiver assistant, or unable to assess. So, we allow for the fact that you might not have to, be able to fill this in. This can be put into a wipe-on, wipe-off sleeve or laminated. And on the back is this body map. So if you've had problems with pain, you have problems with muscle twitching, it literally could be colored. You could draw your finger down and somebody could color for you. So that gives a really good picture about where symptom distress is being experienced. So the guidelines say that people with ALS are living with multiple uncomfortable, bothersome symptoms, and that interferes with function and quality of life. Most of those symptoms have treatments to reduce their severity through medication and other non-drug therapy. Now, that is very much what we use in a palliative approach. We use something called the 3-prong approach. It's a care wheel that says if we want to be really good at symptom management, it's not just about the medications. That's only 1/3. We should be using non-drug strategies, and we should be having meaningful conversations with people and their families, right? So 3 parts of a care wheel here for the best relief. So let's explore that a bit. When we talk about medications, some of these medications are all about trying to slow down the ALS. They're trying to modify it. And there's 3 drugs in Canada that have been approved that I understand. And I am not an expert in those 3 drugs. I am not an expert in disease-modifying therapy for ALS. My expertise is over on the right side here. It's around the symptom management. It's about knowing the medications, the non-drug strategies, and the conversations to address this whole list of common symptoms in ALS. And that's what a palliative approach can bring for you. So I'm going to just quickly walk us through this because I want to leave enough time for discussion. So pain, super common in ALS. And we just need to make sure that we're understanding it and we're assessing it regularly. So that ESAS tool I showed you can and should be used for this. And again, ESAS can be used anywhere. It can be used in people's homes. It can be used in clinics. It should be used in doctors' offices, in hospitals, in long-term care facilities. There's no restriction on where an ESAS could be used as long as a person can engage and tell us. It's the gold standard for the patient's voice to tell us about symptom burden and distress. Okay? And then really our palliative approach would say, okay, Now that you've told us, we want to bring drugs and non-drugs and conversations to address the specific causes of pain so that we can make you more comfortable. One of the things your guideline says is differentiate muscle cramping from other sources of pain. So yes, muscle twitching, muscle cramping, spasticity, or very tight muscles, very, very common. And again, we can take that holistic wheel approach. Some of our non-drug strategies are making sure positioning is good, that an occupational therapist, physiotherapist, stretching exercises, range of motion, heat, making sure people are drinking enough, right? This is super important, drinking enough fluids. We have medications that sometimes can relieve some of the twitching and the cramping. And absolutely, we need to understand, how is this impacting you? How is this impacting quality of life? Is this like one of the most burdensome symptoms that you have? Let's address that. The breathing part, the guidelines talk about how important it is that multidisciplinary care teams are monitoring for signs and symptoms of people being short of breath, and that they're using equipment properly. And a palliative approach would be 100% behind this. And we would say, yes, we know that non-invasive ventilation, so not putting a tube down into your lungs and putting you on a ventilator, but non-invasive, like BiPAP, is the standard of care to treat shortness of breath for people in escalating amounts as disease advances. Oxygen, which, by the way, you notice it's in blue, it's a drug. Oxygen is a drug. It is not routinely needed. It's about a flow of air. So all of us are born with nerves around our mouths. It's called the trigeminal nerve. And the movement of air from fans, from cool air. So if you put some ice in front of a fan, you'll find cool air will feel better than blowing warm air. Even lozenges. You can suck on a lozenge that's very highly mentholated, some of the extra menthol balls, for example. You suck on them, they actually open up and they make you feel, they stimulate that trigeminal nerve that makes you feel less breathless. Secretions like saliva can be managed with drugs. It also can be managed with non-drugs. Sometimes the drugs have upsetting side effects. Like, yes, it worked for that, but it made my eyes really dry and irritated, or made the rest of my mouth really dry. So drugs are not always the solution we want to go for here. Clinicians can work with families, and I'm sure most of you know PROP, so our Provincial Respiratory Outreach Program. And, our goal is always working with PROP and with you to make sure that people have respiratory comfort. Swallowing and nutrition. Guidelines say people should absolutely be assessed by a certified swallowing clinician, and that we're watching for safety and changes in swallowing ability. It should also be followed by a registered dietitian for calories, weight, and dietary adjustments. I just want to say interdisciplinary, so interprofessional, interdisciplinary care planning is all about using a palliative approach. That's how we work. We know that we're stronger as a team. So absolutely, in a palliative approach, your team members should be pulling in your dietitians, your RTs, your respiratory therapists, your occupational therapists, so that these things are happening early. And then that consideration that if you're not getting enough, not able to swallow enough food, if you are hungry, you need to say something. It's not okay. And, losing weight and muscle wasting, we want to try and capture that as soon as we can. So a PEG tube for nutrition, very, very common and very, very safe. Okay? And then I mentioned fluids were important, and fluids can be, while you can drink by mouth, but it can also be given through a PEG tube. People can have additional fluids added into that. And sometimes we even go as far as giving people a little bit of fluid under the skin, usually at night while they're sleeping, and it just goes into the fatty tissue. It's not going into a vein. It goes into the fatty tissue, and it gets absorbed pretty quickly. And it just makes people feel so much better. It's called hypodermicosis. So we can sometimes do that if we can't get enough food or they don't have a peg tube, right? Speaking and communication, just looking at the time here, better hustle. Yeah, you know what can I say? Ability to communicate, your ability to convey what's important to you, what matters to your family, to your loved ones, to your health team, so important. So when the time comes, we need to be using devices that feel right for you. And there can be very low tech, like alphabet boards. There can be very high tech solutions. So it's really about what a person feels comfortable, what is available, but ask what is available. And again, just to reemphasizing that notion that the time to be communicating while voice is still strong about what matters most, what your values, preferences, and wishes are, is early. And that's why bringing a palliative approach into ALS matters. It matters, not just from an advanced care planning, but that you're spending that time well and the loved ones are able to hear your voice. And there are things like voice banks and recording voice as voice starts to fail, because people want that. They want to have that as some of their legacy as well, and for comfort for family members. Emotional responses, I want to say anyone living with a serious illness will experience grief every time functional losses change. And so will family members. They will see the changes. They will understand roles will change, abilities change. And we call that anticipatory grief. And that goes all the way through. Very normal. It's expected. It's an expected type of grief. And it happens as part of adapting to what, is a progressive functional loss. For some people, that grief also brings anxiety or depression. And so again, a palliative approach would bring assessment for that. It would then think about the 3-part care wheel. We would look for supportive counseling. And supportive counseling doesn't have to be a formal service. Supportive counseling can be, a kitchen table conversation and listening by that home health nurse who comes to visit, who's empathetic, who's caring, and who listens. That's supportive counseling. When anxiety and depression impact everyday life and really compromise quality of life, we would consider medications. At that point, we would say, maybe we do need to consider this, but we don't medicalize what would be normal grief and changes in mood over time, unless it's really compromising. And again, who are we guided by? We're guided by you. Energy, sleep, and fatigue problems, very normal. Again, with an advancing illness, people are going to have trouble with sleeping with some of the respiratory, the breathing problems that they have that causes sleep disorder, but so does depression, so do some of our medications. So for all those good reasons, really good assessment by your healthcare team, and then referral to specialized services like sleep clinics. But one of the best non-drug strategies are our occupational therapists. These are master's prepared healthcare professionals who are experts in energy conservation. And energy conversation is an approach to saying, if I only have, 10 spoons of energy in a day, gosh, where am I going to spend it that matters most to me? And how can I save energy so that I have it when I want it? So if what gives you quality of life is your grandkids visiting in the afternoon, but if you do all your normal things without help or assistance, or if you're busy in the morning, you don't even have the energy to do the things that matter most to you. So an occupational therapist will look at your average days. They will make suggestions on how to save energy so you can spend the limited energy you have in a very purposeful way and improve the quality of life. That is a palliative approach. We're almost there. Thinking and behavior, I just want to say yes, I have to acknowledge that there are a percentage of people living with ALS who may end up having changes in thinking and in behavior. And again, we can pick that up early. And that's what the guidelines say. They recognize that we need to be taking, again, that team approach to this, and that we need to be thinking ahead and making referrals to specialists, and then really supporting our caregivers, helping them learn new skills, new competencies, language, ways to respond so that behavior doesn't spiral out of control, so that people whose thinking is muddled now are feeling more supported and less confused. And so I'm just carrying on because dear to my heart is, and I have been on both sides of the fence, everybody, been there, done that. Yes, I've been a nurse for 47 years. I've also been the primary caregiver for 3 parents over a 10-year period, all overlapping, 2 of them with dementia. And I have to say, I know this journey. And so I take to heart exactly what the guidelines say, but what a palliative approach would say, which is, you know what, start early. Don't wait for the strain and the burnout to develop. Start early through connection by, being, allowing where health visits are, sharing. There's lots of resources, both in your ALS BC site and in your Canada site. The Family Caregivers of BC is a fantastic site. It's got a learning hub in there. It's got digital connections for people. And if you've never heard of care mapping, I urge you to take a free course. It's offered once a month from Palliative Canada on Atlas Care Mapping, where it empowers you to think about who and where are the people that can help me. And I have to say, we know from nursing research that people are reluctant to ask for help. They're very reluctant to accept help, and they're very reluctant to organize help. So those 3 boxes, and care mapping solves all of them for you. So that's something for you to explore. Wherever you're located today, I urge you to look at your local health authority, go in your website and see what does my home health programs offer? Who and how do I get connected if I'm not already connected? And please do consider judicious use of in-home and facility respite, and consider it early and often. Sometimes you have to wait to get in for these sorts of things. So it's not a crisis management strategy, but it's about plan breaks that are going to give caregivers a bit of a rest, right? The guidelines do talk about, again, interdisciplinary care, and there's some really amazing outcomes. The data shows us that when you get a team involved, and you've heard me mention different members of the team, nursing, physicians, social work, respiratory therapists, physiotherapists, occupational therapists, well, guess what? People actually live longer. There's a little bit of survivorship that happens there. We know that there's less time spent in a hospital and in an emergency department because changes in health are picked up early, and we've averted crises. And we're using equipment in a way that's really supporting people to live well, and living as well as they can for as long as they can. And that is our motto in palliative care. So a final word, if you came thinking that there was going to be talk about dying, I will mention something, but I think I'm looking at the time and I'd rather take some questions. I'm going to give you a reference, a very important reference for end of life. So the guidelines say, you know what? Start talking early with your loved ones, with your family members, and with your caregivers about what you want at the end of life. So if you're just starting this journey, you may say, oh, that's way too early. I'm not doing this. And that's okay. But when you feel ready, it's far better for us to have an honest conversation about what matters most to you and how we can support you. We can't always change things. We can't always fix things. And as a sort of a tenet of palliative care, but we are here. We never prolong suffering. We don't hasten death. We are here to support people right through to the end of their lives. And there's important stuff to talk about where you want to be. What are the cultural implications? What are your spiritual needs? Are you connected? we can talk about all sorts of stuff with you. And most healthcare professionals are increasingly comfortable in talking about death and dying, bereavement. And, we're here for you. That's what that's about. I'm not going to show the video today in interest of taking questions, but this is a lovely, gentle video. You can go to YouTube. It's called Dying for Beginners. Dr. Catherine Mannix is a palliative physician. She's amazing. She's English and she's got a very soothing voice. And, for some in our society today, it used to be that when we lived intergenerationally, of course we saw loved ones die, grandparents die, We don't anymore. We've become very remote and removed from dying. And what is that all about? And it's frightening for some people. So I hope you watch Dying for Beginners. I hope you go along and are actually comforted by understanding what are those changes that happen at the end of life, what can be expected. And, the vast majority of people with ALS die extremely comfortably. Okay? Vast majority. Yeah. So that's it. We can't change the outcome. We can affect the journey. That was said by Anne Richardson, who was a hospice volunteer and a very wise woman indeed. I'm willing to take some questions, and that's my contact information if that's helpful for you. So thank you. I'm going to turn this back to Alex and to Angela.
Thanks again, Elizabeth. We do have a question comment. You speak of assessment by the team, not in regular contact with. I haven't seen a nurse at home for several years.
I would phone your home health department and ask, I'm living with ALS and I would like to speak with I like to see a nurse, please. So that we use a team, but you may not see all members of the team. You may not see everyone at once. And it's not like coming in where you're going to have a group team meeting. But when there's contact with one clinician, they will pull in other clinicians, and it's usually a home health nurse. So if you've not had somebody coming to visit you and you've been living with ALS, then reach back in. Something's disconnected there because that's not usual.
As of now, we don't have any questions, but if anybody would like to add a question in either the Q&A section or the chat section, please do so.
Is that helpful information? I'd be really interested in hearing whether that was what you were hoping, or if there are other questions that just aren't like, that wasn't what I was expecting. I was needing something more in this direction. I'm happy to support any conversation.
Elizabeth, the presentation, it was a lot of information to digest. I know it's a very limited time, but I think it was very well done, the summary and all the information that you put in there and resources. So
I hope I didn't go too fast for people. If you have questions, by all means, please do just reach out to your home health. Find who your home health team is. And if you're living at home, that would be the first good contact. Most health authorities have something called a central intake now. So you can actually even Google, if you live in Northern Health Central Intake, Island Health Central Intake, same for Interior Health, Vancouver Coastal, Fraser Health. And then just get yourself connected. If that is proving difficult, next time you see your doctor, ask for a referral. Just say, I've not seen a nurse. Nobody's come to my home. I've never had an occupational therapist come and assess the safety of my home. It sometimes takes self-advocacy to be able to get connected. And I'm not Pollyannish about this. I do think that people fall through the cracks. So self-advocate, be a strong voice for yourself and for your loved ones, and get yourself connected. Yeah. I saw that as Nina says, I take screenshots and I revisit the session. I'm happy to PDF this and send this to you, Alex, and then you can pop it out if people will wish to review it themselves and at their own time and speed as well. So,
yeah, absolutely. I really appreciate that. And I also have another comment. So thank you for a very informative presentation.
Well, you're very welcome. And I hope it took some of the fear out of the P word. Palliative is nothing to feel afraid of. It's all about comfort, and it's about improving quality of life and supporting people who are living with serious illness. So, yeah, great. Thanks, Roger. All right. Well, if there is no further, I can go back and I could show a little video if people want to make their choices. Otherwise, we could just send it and then people can choose from there. What do you think, Alex?
How long is the video?
3 minutes.
Oh, okay. If you prefer, if we don't have any other questions, yes, we can show the video.
Yeah.
Also, the presentation has been recorded, so anybody can go and watch it later on our website.
Okay. I'm gonna go back. Well, actually, you know what? Let me just stop sharing for 1 sec here. I just want to share a different thing. I'm gonna give the trigger warning to people. So if you are not ready to hear or think about dying or what dying means, then I would say that's okay. And so feel comfortable, please, to sort of end being on board here. And you don't need to watch this. It is a very short video, and as I mentioned, a very gentle video. But again, it may stimulate thought, and it may stimulate questions that have you wanting to make sure that you get answered from people, right? So let's have a listen to Dr. Catherine Mannix just explain dying, what dying is about.
I want to tell you what normally happens as someone is dying. Dying, just like being born, is a process our bodies go through quite naturally, with recognized phases that are pretty much the same for everyone. It's all very ordinary. At first, our bodies grow weary. We need more sleep, less food. We may lose our appetite altogether. Some days we can manage an outing or visitors or watching TV. Other days we mainly sleep. All this is normal. Inside our weary bodies, changes are happening. All our systems are running out of energy. Digestion slows down. Our heart may not pump as strongly. Our organs might slow down. All normal. Aside from the physical, I've noticed that dying people's perspective often shifts from themselves to others. The same last messages. I'm sorry. I forgive you. Thank you. I love you. Most people are not conscious by the time they die. We don't know when we're unconscious. We don't notice time passing or feel our body. It doesn't feel like going to sleep. It's just a state of non-awareness. To begin with, dying people might only be unconscious some of the time. In between, they may wake up and talk, or sip drinks, or listen to the people around them chatting. That's normal. They may become a bit muddled or restless. It helps when people hold their hand and talk in soothing, gentle tones. Familiar, trusted voices calm and comfort. Unconscious people breathe in an unusual way. Their breathing pattern gradually changes backwards and forwards between deep and shallow and between fast and slower breaths. This is normal, and they can make unusual noises. If their breath vibrates their voice box, it might sound like a sigh or a moan. Sometimes their breath gurgles or rattles. It's not uncomfortable. It's a completely normal part of dying. Hearing is the last sense to go. That's why loved ones and caregivers can keep talking while the dying person is unconscious. It's why some people make end-of-life playlists. What about the moment of dying? Well, it's usually very gentle. Our breathing gets slower and more shallow, and then it just very gently stops. A few minutes later, our heart stops too. That's it. No fuss or fear or panic. Of course, saying goodbye to people we love is sad, but knowing what to expect takes away a lot of the fear. I've met so many bereaved people who wish they had talked about dying more. I never met a person who regretted having those important conversations. We need to talk about it, because talking about death will help us to live together better.
That's it. Were there any questions from that? Yeah, any questions from the video or any concerns? I can put the link to the video in the chat as well for people, so that if it's something you want to share with family and loved ones, you certainly can do that as well. But it's a video that's brought a lot of comfort for a lot of people and taken some of the mystery and some of the fear out of dying at the end of life. So, all right. Thank you for inviting me. I do appreciate it. And if there are any questions afterwards and you need to reach back, you know how to get hold of me, Alex.
Yes, thank you so much, Elizabeth and Angela. Thank you for sharing all this information. It says from one of the members said, thank you, thanks a lot, good information. So been very helpful.
Pleasure. All right. Have a good afternoon, everyone. Bye-bye now.
Bye.
Bye.